or good afternoon according to your time zone. I'm Dimitrios Goulis, a reproductive endocrinologist from Greece and currently the president of the European Menopause and Andropause Society, the EMAS. It's my pleasure to welcome you to this EMAS webinar on estrogen and progestogen choice for breast safety during menopausal hormone treatment. Indeed, one of the main reluctances, if not the major one, for prescribing menopausal hormone treatment is the fear for breast cancer. Today, we will discuss exactly this issue. Is this fear justifiable? If yes, how can we reduce it? Dr. Premitha Damodaran from Malaysia will give us all the necessary theoretical background, whereas Professor Tsai Yung-Chieh from Taiwan will present two cases to practical implementation of the theory. Before we begin, EMAS would like to thank Abbott for their support and for making this new webinar series possible. Nevertheless, we must clarify that the scientific program and its contents are exclusively the responsibility of EMAS. Moving on to technical issues. You have entered the webinar into listen-only mode. This means that your microphone is muted, so we do not pick up any noise from your end. We do welcome and encourage actually you to submit your text questions via the Q&A widget located in your Zoom panel. Please search it from now. You can enter your questions at any time, and we will be very happy to read and discuss them during the end of this webinar. On top of English, this event is translated and you can choose one of the following languages. It's Russian, Chinese, Mandarin, Spanish, or Portuguese. You may select the language by clicking on the interpretation widget you will find in your Zoom panel as well. Finally, I remind you that we are recording today's webinar and it will be available on the EMAS website. So it's my great pleasure to present you Dr. Premitha Damodaran. Dr. Damodaran is consultant obstetrician and gynecology, used to be the chair of the menopause subdivision of the Obs and Gyne Society of Malaysia, and she is the current chair of the Working Committee for the Clinical Practice Guidelines on Management of Menopause in Malaysia. So I think you agree with me, she is fully suitable to discuss with us the relevance of estrogen and progesterone choice for breast safety during MHT. Premitha.
Thank you, Professor Goulis. Good evening, good afternoon, good morning, ladies and gentlemen, all around the world as this is being translated. I would also like to thank EMAS and Abbott for inviting me to talk today. Now, I come from Malaysia, and in Bahasa Malaysia, the Malaysian language, emas stands for gold. And that's really very appropriate because we are dealing with the golden age of men and women. Now, let me share my slides. I've got a very important topic to talk about today. That is the relevance of estrogen and progestogen choice for breast safety. These are my disclaimers. As I said, I come from Malaysia, a very, very small country surrounded by, we have Indonesia, Philippines, Singapore all around us. We have got beautiful beaches and we have high, tall towers and buildings. But what we are really proud about is our multi-ethnic population. And despite being multi-ethnic, a lot of our women are still going through a lot of menopausal changes, but sadly, a lot of them are scared to take menopausal hormone therapy, mainly due to the breast cancer risk. Now, I have been dealing with menopausal hormone therapy or hormone replacement therapy, as it used to be called, since the last 25 years. And what a change we have had. What started as the elixir of youth has now become a drug that many physicians are scared to use They are worried. They do not know how to counsel their patients. And because of that, many women actually suffer. And these fears actually came about with WHI. And we know that how much of an impact WHI had on healthcare workers, on doctors, on patients. Despite the fact that WHI spoke about the risk of hormones on the heart, on DVT, and breast cancer, it was actually breast cancer that actually scared the women. And because breast cancer is seen as the greatest lifetime medical risk, I've got a dry throat. Okay. Now, if you go back to WHI and you look at the actual stats from WHI, we had two arms to the WHI. We had women who were on the estrogen and progestogen arm, which showed an increased risk of breast cancer because of the fact that there were these preset guidelines of what they would use. And when those preset guidelines on breast cancer got exceeded, they stopped that study at 5.2 years. However, the other arm, where hysterectomized women only went on estrogen, that went on till 6.8 years when it stopped due to strokes. But no one talks about the estrogen only arm so much. Every time WHI is said and is talked about, it's always the fear of breast, cardiovascular, or VTEs. But WHI has taught us a lot of lessons. And I think that's our take-home message for today, because we have come to understand that there are different types of estrogen, and the different types of estrogen have different effects. We now know about how the conjugated equine estrogens deal with the breast, the estradiol hormones, and transdermal estrogens, and whether vaginal estrogens actually have any effect on breast. We now know that progestogens really matter. The type of progestogens, whether they are taken orally or the transdermal combined route, or whether we use a levonorgestrel intrauterine system, or we move away from estrogen and progestogen or only use tibolone, we have come a long way, and we have fine-tuned our treatment of menopausal hormone therapy. Now, I'd like to divide this lecture into 4 parts. The first part would be, what is actually the effect of estrogen on the breast? Now, we've all heard about the fact that lifetime exposure of estrogen would increase the breast cancer risk. But is it really so? We have now come to understand that early menarche actually carries a higher risk of breast cancer than late menopause. We have come to understand that a woman having a child age of 35 actually has a higher risk of breast cancer compared to one who doesn't even have any children. But at the same time, we know that women, younger women with many kids, and every time they get pregnant, they are exposed to high amounts of estrogen. Actually, they have a protective effect. Or the women who menopause early and they go on hormone replacement, we know that their risk of breast cancer is actually not there. So is it actually estrogen that increases breast cancer risk? Now, we also know that it matters how we take our estrogen. If we take it orally as oral estrogen, oral estradiol, we know that it changes to estrone, which is supposed to be the bad estrogen, and that can actually increase the risk of VTEs, strokes, and coronary heart disease. Whereas if we use it through the transdermal route, the skin, you have more estradiol. You need lesser amount of estradiol levels, and it's only very little that gets converted into estrone. We also know now that vaginal estrogens do not increase the risk of breast cancer. Now, the Finnish study that came out in 2006, which looked at women who were on oral and transdermal estradiol, a huge number, over 85,000, or the group that took oral estriol, vaginal estrogens for at least 6 months between 1994 to 2001. And they were followed up till 2002. Now, what did that study actually show? It actually showed that there was increased risk with oral estradiol after 5 years of use, which was dose dependent, especially if one goes on more than 1.9 milligrams per day. There was increased risk with transdermal estradiol, but this was not dose dependent. There was no increased risk with oral estriol. There was no increased risk with vaginal estrogens. So now we move on to the progestogens. Now we have come a long way to understand how progestogens actually work. And we now know that all progestogens are not the same. They have different effects via their biological activity, their intracellular actions, especially how they bind through the androgen, glucocorticoid, and mineralocorticoid receptors. Now, this is a chart that we actually often see. But now that we look at it in a little bit more of a different way, and we look at dihydrogesterone, which is now considered the safer progesterone. And then we look at the ones that are now what we would like to stay away, the progesterones that we're trying to stay away, the medroxyprogesterone acetate, the noretestrone, the levonorgestrel. And if you look at the difference between the dihydrogesterone and the last three, you would see that these are more progestogens that have got androgenic potential and the ones that have got the glucocorticoid potential. So is this what that then increases the breast cancer risk? Now, this is very clearly seen in the French cohort study and the Finnish cohort study. And in both these studies, when they looked at the huge number of women in the French cohort, 80,000 women, in the Finnish cohort, about 50,000 women who went on hormone replacement therapy for more than 5 years, and in the French cohort, 8.1 years. And if you looked at these women and they broke these women down into what type of progestogen that they were using. And if you really looked at the subdivisions of these bars, you would see that women who went on estrogen and progesterone, women who went on estrogen and dihydrogesterone did not increase the risk of breast cancer. Similarly, in the Finnish cohort study, women who went on estradiol and dihydrogesterone not increasing their risk of breast cancer, while women that went on estrogen plus other progestogens, especially MPA, the noretestrone, and other progestogens, clearly increasing the risk of breast cancer. So that actually started our mind working on the type of progesterones. Now, the third thing that I'd like to discuss, which I think is really very important, is the mammographic breast density. We know now that increased breast density is an independent risk factor for breast cancer. When one is on estrogen or a low dose transdermal combination, there is less impact on breast density. But combined oral EPT preparations have been found to increase that breast density with a greater frequency of abnormal mammograms. And this risk goes on for about 12 months after discontinuing the hormone replacement therapy. Now, let's go back to the French study, and we look at data that just came out last year. And they looked at the association between menopausal hormone therapy, mammographic density, and breast cancer risk. And it was clearly seen that the percentage of density was higher for a current user compared to a past user or a never user. And nearly half of the effect of menopausal hormone therapy on hormone receptor positive breast cancer risk is mediated by the mammographic density. And this can be actually modified up to 8 years after menopausal hormone therapy termination. So this is really very significant. Now we put all this data on estrogen, progestogen, and mammographic density, and we now look at the current literature and the 3 main studies that actually came up in the last 3 years. Now, the WHI study has been followed up now for about 20.3 years and clearly showing us the direction of how to manage our menopausal hormone therapy patients, our patients who need menopausal hormone therapy. We now know that conjugated equine estrogens alone for hysterectomized women was significantly associated with a lower breast cancer incidence and a lower breast cancer mortality. But yes, CEE plus medroxyprogesterone acetate definitely increased the breast cancer incidence, but there was no significant difference in breast cancer mortality. But what put the spanner in the works was the collaborative group that came up with data in Lancet in 2019. Now, this again brought about those vibes almost like how WHI data came about, because it clearly mentioned when they grouped all these 53,000 women and they matched it with 100 over 1,000 women without breast cancer. When they matched everything together, it clearly came up with the fact that even if one went on just estrogens, there was an increased risk. If when one went on oral or transdermal, there was an increased risk. And the increased risk with estrogen progestogen preparations was clearly seen with levonorgestrel, norethistron acetate, and medroxyprogesterone acetate. In this study, in this group of analysis, micronized progesterone and dydrogesterone was considered as a rarely used hormone and not studied. Now, looking at that particular Lancet epidemiological data, the whole group of the British Menopause Association, the International Menopause Association, AMAS, RCOG, and the Australian group then decided to come up with a proper structured way of addressing these fears. And this was really very important because the Lancet journal had to be taken in context with other studies that were showing us a clear path. Now, this made it very easy for us to then advise our patients appropriately. And it clearly showed that women who at the age of 50 started taking menopausal hormone therapy and their risk of breast cancer between 50 to 69 was said to be 1 extra case. That means that those who were taking continuous combined, you had 1 extra case in 50 women. For the sequential, 1 extra case in 70 women, and the estrogen only users 1 extra case per 200 women. The 10-year intake of menopausal hormone therapy then went on to have 2 extra cases. So this made it very much easier for us now to counsel our patients appropriately. So 2 extra cases down the line, continuous combined, sequential combined, and estrogen only. Now, the other very important data that came about was the Vinogradova study that looked at the UK cohort. Now, this UK cohort actually looked at about 100,000 women, and they matched it to almost 500,000 women using the UK GP registry. And they looked at women who were on different types of estrogen, who were on different types of progestogens, and then they looked at the breast cancer risk. And clearly it was shown that estrogen-only therapy did not increase risk. Short-term, that is less than 5 years of estrogen progestogen therapy did not increase risk, but long-term therapy clearly increased the risk of breast cancer. Now, the biggest risk was with norethistron, and the lowest risk was with dydrogesterone. Now, when these women in the Vina-Gradova study was actually broken down into the type of progestogens, we clearly see that there was a higher risk of breast cancer with medroxyprogesterone, levonorgestrel, and norethistron, but not associated with any significant increased risk with the dydrogesterone group and the tibolone, especially when taken even long-term and more than 5 years. So now when we are counseling our patient and we have them across our table, we are actually looking at them as a whole, and we have to individualize our therapy. We need to look at making them feel better, giving them that quality of life. We have to look at relief of climacteric symptoms. We need to look at maintenance of their health throughout the menopause. And we also have to look at lifestyle changes and what we can do to actually make them better and have a better golden years of their lives. We know, and without a doubt, and we cannot deny the fact that estrogen remains and will always remain the best treatment for climacteric symptoms. And across the world, we know that this is the #1 treatment, and women should be started early, not late. Women should have an appropriate dose, which may be a low dose. And the most important thing is that we need to always individualize therapy. We also know that when we look at number of years of hormone therapy, and then we look at the fact that how the breast cancer risk increases, on the other hand, breast cancer takes many years to develop. And we know it is a time-related issue. So sometimes when we look at the fact that we say that hormones actually hasten the process of breast, the cancer tissues, it makes cancer develop faster. On the other flip side, why is it the fact that when one stops hormone therapy after a set period of time, the risk of breast cancer actually regresses down to baseline? Because if it is already triggered breast cancer cells, it should continue going on to breast cancer much faster. So lifestyle becomes very, very important. So let's not only look at risk of menopausal hormone therapy and breast cancer. We have to look at that woman and her lifestyle. We know clearly that a woman with a higher BMI clearly has an increased risk of breast cancer. And if a woman exercises and does even about 2.5 hours of exercise every week, clearly increasing her risk of breast cancer, instead of looking at numbers of estrogen or estrogen and progestogen, let's look at her lifestyle. When we look at the recent WHO figures, we know that in the next 20 years, and this is the era that we are in, there is going to be a 50% increase in cancer burden. And when we look at breast cancer, we know that one of the key factors is postponement of children and having fewer children. Also, greater levels of excess body weight and physical inactivity that actually then increases the risk of breast cancer. Let's come to Malaysian data. And this is the Malaysian data that we have that came out about 3 to 4 years ago. Unmatched data, but giving us a lot of info of what is happening in my country. So here is data of about 3,683 women and equally matched. This was based on 2 main hospitals that dealt with breast cancer, and these 2 hospitals actually covered about 10% of breast cancers in my country. Now, the age incidence of breast cancer was about 47.4 over 100,000. But when you actually looked at the risks of breast cancer, or risk factors and the risk of breast cancer, we clearly see that breastfeeding, and one breastfeeds for more than 1 year, you get 70% decrease of the breast cancer risk. We know that if the BMI here in this country goes up to more than 27.5, there is a 52% increase of breast cancer risk. And higher level of physical activity, clearly making the breast cancer risk much lower. If you look at the data that we have in this country of a woman going on COCs or MHTs, it does not affect breast cancer risk at all. Now, about 15 years ago, I was standing in this huge hall talking about hormone replacement therapy and the risk of breast cancer. And at that time, again, talking about the +1 numbers and the +2 numbers. And towards the end, there was a gentleman, a doctor, who stood up and said, my mother was that +1 who had breast cancer after menopausal hormone therapy. Now, that has always remained in my head when I'm counseling my patients, because I think that's very important to empathize with that woman and to treat her correctly. So our take-home messages today is actually having individualized treatment for our women. We should be using low-dose therapy. We should be using the correct estrogen and the correct progestogen. We should be looking at non-oral routes for certain women. And most of all, especially with this era of COVID and many not coming back for treatment or follow-ups, we should always emphasize on regular follow-ups, and we should always carry a risk-benefit assessment at every visit. Now, just about a month ago, this came out in the Climactric, and it was published online. Menopausal hormone therapy, why we should no longer be afraid of the breast cancer risk, by Professor Dr. Delphine Tan and group, and clearly stating that the breast cancer related to estrogen and progesterone therapy is rare because the risk is low. Modifiable lifestyle factors are the real risks. The reported increased risk with EPRT is not relevant anymore because we are all now shifting to micronized progestogens and dydrogesterone. And most of all, think about that woman, and if she really needs menopausal hormone therapy, we should give it to her to make her feel much better. Now, this photograph is with permission. And this is a patient of mine who is a breast cancer survivor. She has a very interesting story. About 5 years ago, I got a call from the breast doctor, the breast surgeon who looks after her. This lady, who was then 50 years old, was found by her husband about to jump off the roof of an 18-story building. She was on 3 types of antidepressants after going through her breast cancer surgery. She was complaining of hot flushes, inability to sleep, restlessness, and her breast doctor, knowing that this could be menopausally related, called me up to help look after her. Ladies and gentlemen, this lady went on menopausal hormone therapy for about a year before we called it off. She went off all her antidepressants. She is now 4 years past, she's into 5 years post her breast cancer and doing very well. Today is International Women's Day all around the world. Break the bias. Ladies and gentlemen, let's treat every woman as an individual. Good night. Thank you very much.
Thank you very much, Premitha, for this very concise, informative, and educational lecture. There are many congratulations for you already in the chat. Professor Tsai Yung-Chieh from Taiwan accepted the task to bridge the theory with clinical practice by presenting a couple of educative cases. Professor Yung-Chieh is the director of the Department of Obstetrics and Gynecology at the Tsai Mei Medical Center in Taiwan. He's an associate professor in the Chai-Anand University of Pharmacy and Science in Taiwan and a council member of the Asia Pacific Menopause Federation and a past president of the Taiwanese Menopause Society. We will take advantage of his extensive experience for learning how to choose the appropriate estrogen and progestogen regimen for achieving the maximum breast safety when we prescribe menopausal hormone treatment. As usual, please remember to use our Q&A facility widget for your question. Tsai, please.
Okay. Can you see my slide now?
Yes, just please go to presentation mode.
Okay. Thank you, Mr. Chairman, for your kind introduction. Also, thanks to Amos and Albert for inviting me to join this webinar. I'm Dr. Tsai from Taiwan. Here I present two cases which were related to the estrogen and the progestogen choice for breast safety during menopause hormone therapy to share and discuss with you. This is the first case. She's a 51 years old female. She has 2 kids, menopause for 1 year. Her body height is 160 centimeter and her body weight is 50 kilograms. She suffered from insomnia and hot flush recently. She ever received incision for benign breast fibroma before and still have some fibromas in her breast. She came to your clinic and asked for hormone therapy to relieve her discomfort. And the question one is, will you or will you not give her hormone therapy and why? And the question two, if the answer is yes, what will be your prescription? And my recommendation for this patient will be based on her previous pathological result of breast incision and the current breast echo finding. If the present echo finding is normal and her previous breast mass is a simple fibroma, and because a simple fibroma does not raise the risk of breast cancer, then I will suggest her go on to take the hormone therapy. However, if there is a concern about her present breast echo finding or her previous breast incision pathology is a complex fibroadenoma, then I will suggest her consider a non-hormone treatment to relieve her vasomotor symptom. But because having the complex fibroadenoma can raise the risk of developing breast cancer. And if the patient decides to take the hormone therapy, then Premarin will be my first choice of prescription. Because after 20 years of follow-up of the WHI study, Premarin has been proved to be protective against breast cancer. And this is the first evidence of its kind. And whether the protective effect extends to all estrogen is still questionable. Here is the paper published in JAMA in 2006 about the WHI study. And you can find there is a non-significant reduction for invasive breast cancer and then the total breast cancer in women randomized to Premarin alone. And after 13 years of follow-up, another paper published in JAMA in 2013 also indicate while treatment with Premarin plus Povera increased breast cancer incidence, there was a significant reduction in breast cancer seen with Premarin alone. Most recently published in JAMA in 2020, after 20 years of follow-up, use of Premarin compared with placebo was associated with a significantly lower breast cancer incidence. And the overall median length of follow-up for participants receiving Premarin alone was 16.2 years and 20.7 years for those joined in extension. And for participants receiving Povera, the overall median length of follow-up was 18.9 years and 20.7 years for those joined in extension 2. However, if the patient is not comfortable with Premarin and she wants to choose another estrogen, because there is still concern about the long-term estrogen exposure might increase the breast cancer risk, I would suggest the patient start with a lower dose of estrogen to relieve her vasomotor symptom. Low dose estrogen is often considered to be 0.3 milligram or less of conjugate estrogen, 0.5 milligram or less of oral micronized estradiol, 2.5 microgram or less of estradiol, or 25 microgram or less of transdermal estradiol. As for duration, here is the guideline on menopause hormone therapy from different professional society. For example, the ACOG suggests the duration of use should be based on risk and benefit analysis, which recommend against routine discontinuation in patients more than 65 years of age. But for AACE and the ACE, the recommendation from these two societies is recommend less than 5 years of use. Longer term of use is still controversial, and the reduced dose if continuing. And as for the type of progestogen, there were data suggest, based on the divergent breast cancer incidence between Premarin alone and the Premarin Povera arm from the WHI study, a causal role of progestin was hypothesized in breast cancer development. There were data suggest micronized progesterone or dydrogesterone may be associated with better risk profile for breast cancer. This is the result from the French E3N cohort study published in Breast Cancer Research Treatment in 2008. The goal of the study was to assess and compare the association between different hormone therapy and the breast cancer risk. And during follow-up, 2,354 cases of invasive breast cancer occurred among 18,377 postmenopausal women. And identifying the association of estrogen-progestin combination with breast cancer risk varies significantly according to the type of progestogen. The relative risk was 1.0 for estrogen progesterone and 1.16 for estrogen dydrogesterone. And 1.69 for estrogen combined with other progestin. Another paper from Finland also indicated the risk of elevation of breast cancer risk may not be uniform for all progestogen. So this is the guideline from the International Menopause Society, and it says the micronized progesterone or dydrogesterone used in association with the aura or percutaneous estradiol may be associated with a better risk profile for breast cancer than other progestogen for at least 5 years. And of course, if the patient is not suitable for hormone therapy, then she can choose non-hormone therapy. The non-hormone therapy can either be pharmacological, such as SSRI, SNRI, or non-pharmacologic. Non-hormone therapy that have been shown to reduce hot flashes include low-dose SSRI, SNRI, gabapenitoid, weight loss, hypnosis, and cognitive behavior therapy. And here comes the second case. She is a 50-year-old female. She has 1 kid's menopause for 2 years. Her body height is 158 centimeters, and her body weight is 60 kilograms. She suffered from insomnia, hot flash, and severe emotional instability recently. Her mother was a victim of breast cancer, and she came to your clinic and asked for hormone therapy to relieve her discomfort. And the question one is, will you or will you not give her hormone therapy, and why? And the question two is if the answer is no, what will be your recommendation? And we have to be aware the risk of breast cancer in women who have a first-degree relative with breast cancer is twice as high as that in other women. So my answer recommendation for this patient to take HT is no. And actually, there are different recommendations for hormone replacement therapy in various breast conditions. For example, if the breast condition is normal and it's yes, you have the green light to take the hormone therapy. But if the patient have a benign breast disorder, then the answer is yes for the low risk regions, but no for high risk region, except for short-term low-dose HT only in intractable cases, and the patient must know about the potential risk. And for the breast cancer survivor, my suggestion is no, because they still have the increased risk of recurrence after hormone replacement therapy in breast cancer survivor. And if the patient have a family history of breast cancer, and then she should be managed with non-hormone option in the first place. And the short-term low-dose HT should only be used in intractable cases who have been informed about the possible risk. And for the BRCA1 mutation carrier post-oophorectomy, and she should be managed with non-hormone option in the first place. And fortunately, use of estrogen alone hormone therapy after oophorectomy does not increase the risk of BRCA1 associated breast cancer. Of course, the potential harmful effect of progesterone-containing HT warrant further study. So I will suggest this patient to take a non-hormone therapy, as I have described in my previous presentation. With this, I thank you for your attention.
Well, thank you very much, Professor Tsai, for this very comprehensive, informative, and practical presentation. Dear colleagues, I must thank both invited speakers as they clarified many issues regarding the indications, the contraindications, and the prescription of the most suitable estrogen and progesterone regime for achieving the maximum breast safety. Nevertheless, a good lecture always provokes questions. So we are waiting for yours. Please use the Q&A widget located in the Zoom panel. Some questions have already arrived thanks to your clear presentation. And I would like to start with a question from Kalanika Hapola saying that when we say that estrogen and progesterone increase breast cancer, let's say from 3 to 4 per million, do hormones promote cancer growth or just enhance the growth of an existing tumor growth? Premitha, would you like to answer this?
So I think if a woman is going to get breast cancer in her life and say that she is going to get breast cancer at the age of 65, and that's her inherent risk, going on hormones would make it faster. But on the other hand, we do know that women who are on menopausal hormone therapy are likely to also find out about any breast changes earlier. So it's all about detection, because women who are on hormones would then automatically have their mammograms, breast ultrasounds done earlier. So is there a bias to this? We have no idea, and I don't think we will ever know. So it's always important that women who, even before they start on hormones, and this is what I would always insist on my patients, have a routine screening done and then go on it and have regular screenings done. So at the end of the day, we are also balancing the hormones with their quality of life. So they might get a lot of relief from their vasomotor symptoms, help them with their bones, help them with the genitourinary menopause symptoms, and use that as the benefits versus that tiny risk of breast cancer. So it's a lot of issues that we need to look at.
That's excellent. And as far as you have touched this issue, I have another question saying that women with high breast density at menopause, do you recommend regular ultrasonographic examination as well for the follow-up of these women?
Yes, I usually insist on both a mammogram and an ultrasound as a starting point. And then if they have high breast density, it would always be better to always use an ultrasound regularly on a yearly basis to detect any issues that come along the way. Yes.
Thank you very much, Premitha. I have two questions about the intrauterine devices, actually, with levonorgestrel. Most probably Professor Tsai may answer them. So compared to the breast cancer risk after transdermal estradiol and dydrogesterone, what would be the estimate for using the intrauterine device? Is the breast cancer risk increasing or not with the use of the device?
Well, Basically, the intrauterine progesterone device should have a very low blood concentration of progestin, so the effect on the breast density or on the breast should be limited. So basically, it should be okay to use the IUD, for example, Mirena, the progesterone content intrauterine device for protecting the uterus. If you take the hormone therapy with uterus, yeah.
I see, thank you. And continue on the same ground, comparing efficacy at protecting the endometrium during MHT. How are the results of the progesterone, natural progesterone, and the standard levonorgestrel device, the Mirena, use it in Europe? Do they have the same protection regarding the endometrium?
We should be very aware about the progestin and the effect of the endometrium protection. Different progestin have different effect on the endometrium. For example, Provera maybe have some bad effect on the breast density or induce breast cancer, but Provera is very effective in endometrium protection. And but for estrogen or dydrogesterone, for example, for estrogen, their protective effect of the endometrium maybe not so well as the Provera. So when we use the different progestin to protect the uterus, we have to be very aware. It should be very individualized. For example, if the patient takes a base is very fat, and the patient takes high dose of estrogen, the dose of the estrogen should be increased. So you have to regularly follow up the endometrium condition after you give patient different kind of progestin to make sure the endometrium has been protected well.
Thank you very much. That's a clear answer. We go back to Premitha as well. We have some questions about positive family history of breast cancer. There is a general one by Kalani Kahapola saying that how would you counsel in general patients with positive family history of breast cancer in the immediate family? And Panagiotis Anagnostis from Greece, it makes it more specific. Why, he says, why not to calculate the absolute breast cancer risk in a woman with a positive family history instead of refusing MHT? If it is less than 2% for the next 5 years, this is not a contraindication for MHT according to international guidelines. So your comments, Premitha, about family history of breast cancer?
Well, I think family history is very important, but I'd like to know more about that family history, because I'd like to know if the relative had breast cancer at an older age, or was it at a younger age? And I think that's very significant when I decide, whether this lady should go on hormone therapy. Now, that's one. Number two is the fact that family history of breast cancer is not something that we should deny a patient in need of hormone therapy. If a woman is actually suffering from vasomotor symptoms and a lot of issues and is down and depressed, she should be offered hormone therapy. We can always choose the right hormone therapy for her. We can use the right estrogen, we can use the right progestogen, we can give her non-oral forms, everything that we now know would support that woman and decrease the risk of breast cancer. And we can give it to her at a low dose for a short possible period of time. So we should not deny that woman menopausal hormone therapy if she is one that actually really needs it. Keeping that family history background, knowing about it, keeping this woman closely followed up is actually very important.
Thank you very much, Premitha. Professor Tsai already talked us about the use of other medication on top of MHT. This is a question from Russia. So the colleague asked, thank you for the excellent presentation, if you cannot take menopausal hormone treatment and use phytoestrogens, then how can a woman be protected from osteoporosis and vascular disease?
First, I will have some comment about the family history of breast cancer. We know when a patient have one first degree of relative have breast cancer, and this patient will have twofold of getting the breast cancer, twofold of chance to get the breast cancer. If the patient have two first degree relative have breast cancer, then this patient will have threefold of chance to get breast cancer. Now the patient have a choice. We still have a lot of non-hormone therapy to relieve her vasomotor symptom. So in this kind of situation, I would suggest the patient to consider the non-hormone therapy to relieve her vasomotor symptom first. And if this treatment is ineffective, then she can go on with the hormone therapy very carefully. This is my opinion. Okay. And as for the phytoestrogen, because the quality of phytoestrogen varies significantly from different countries, and there is no guarantee for the source or the product. For example, maybe some the material of phytoestrogen is produced from China, anywhere else in the world. I mean, the quality of the source is not so reliable. So the effect of the phytoestrogen, it has not been proved scientifically in most of the papers. Yeah.
Thank you very much. This is a very important message that the quality of this preparation sometimes may be quite variable. We have some questions about the use of continuous or sequential combined MHT. So we are returning back to Premitha. Once again, thank you for your presentation. Which regimen do you recommend, continuous or sequential combined MHT? And to refer this to the breast cancer, is there any difference in breast cancer using progesterone for 10 days a month or use it every day?
Okay, so we're back to sequential and continuous combined. So sequential, what is actually recommended is about 12 to 14 days for endometrial protection. And that's what's recommended. We do know that the risk of breast cancer actually increases slightly with continuous combined therapies compared to the sequential therapies. And if you look at the combined study from when we looked at the IMS, BMS, AMS recommendations based on the Lancet 2019, we know that the risk of breast cancer, if you look at a 5-year data, as actually 1 by 50 for someone who is on a continuous combined and 1 by 70 for someone who is on the sequential therapy. Now, what would I recommend for my patients? Now, I would use the simple guidelines that we always use, that if a woman is within that 1 year of her last period, I would give her the sequential therapy. If she is past 1 year, I would then give her the continuous combined therapy. So this would be the general guidelines that I would always use. But at the same time, I do know that some women who are on the continuous combined therapy, even whatever dose that I tweak it to, sometimes get a lot of breakthrough bleeding, and they're actually happier to go on the sequential therapy where they do get scheduled bleeding. So that would be, again, individualized treatment and then going to what makes them happy at that particular point.
Thank you very much, Premitha, for this very practical guidelines of how to use sequential or continuous MHT. There is a question from China, so most probably Professor Tsai would be a little more aware about this. And this is what's the average treatment duration of your patients? Is it long? Is it just a few years? And how do you persuade or manage your patient to take MHT for a longer period of time? So,
well, according to the guideline from the IMS, and woman, I usually suggest my patient to take the hormone therapy until they reach the 60 years old, unless they have a severe symptom. Unless when they stop the hormone therapy, they feel very uncomfortable, suffering from the vasomotor symptom, then she can continue with the low dose hormone therapy. Otherwise, I would suggest she can stop the hormone therapy until 60 years old. This is my usual prescription.
Mm-hmm. Let me see.
Can I come in? My oldest patient is now 80 and she refuses to stop hormone therapy.
Yeah, I agree.
She's got an intrauterine system in and she just puts some gel on and I can't convince her to stop at all.
Yes, sometimes we will have patients who cannot stop the hormone. She just like it.
Very nice. And continue with this. We have a question by a psychologist asking that, are there any situations where it is safe to prescribe MHT after 10 years postmenopausal?
I think I would then again look at the simple guidelines that we have and assess that particular woman, because we do know that the risk for that woman increases after 10 years of menopause, especially to the heart. So now comes to the question of why does she need menopausal hormone therapy? What is the background behind it? Is she having vasomotor symptoms? Then we can go on to a non-hormonal therapy. Is she having a bone issue? Then we can go on to actual bone drugs rather than going on to menopausal hormone therapy. I think we need, and if she has a genitourinary problem, then we can then go on to very specific drugs or treatment for that particular area. So I think it comes to the fact that why does she need it after 10 years and what is the background behind it? And then we deal with it accordingly.
I totally agree with you, because we know there's a window of opportunity for hormone replacement therapy. After 10 years of menopause, maybe the patient's blood vessel is not so healthy. If the patient have established atherosclerosis, then the hormone therapy maybe accelerate the formation of the atherosclerosis and put this patient in danger of cardiovascular disorder. So I won't suggest the patient to take the hormone therapy after 10 years of menopause. But I will agree with we started. I'm sorry, Damodaran. Her opinion is very good for the patient. We should treat the patients. Why we should ask the patient why she need hormone therapy. Instead of give her the hormone therapy after 10 years after menopause.
Very nice. And we have mentioned vaginal estrogen, and some women have especially this problem, genitourinary symptoms rather than general symptoms. So, Premitha, a colleague asked, are vaginal estrogens safe concerning breast cancer?
Well, the data is showing that vaginal estrogens is safe because there is very little systemic absorption. But I would still sort of fall into a safety zone and say that if I'm going to use a vaginal estrogen, it is going to be for a short term and then we assess and see, because I have no idea whether that for that woman, her systemic absorption would be much more. So I would still err on the side of safety for that particular woman. And there are a lot of other treatment for vaginal, for the genitourinary syndromes of menopause. And we know that, there are a lot of other new agents that are coming up that may actually work very much better and safer.
I agree with Dr. Damodaran. Especially if the patient can use the E3 vaginal cream, is very safe. more safe than the E2 vaginal cream.
There are many questions, and this is a consequence of your very clear and informative presentations. If the presentation are of appropriate quality, then we usually have a lot of answer. I have one final question, actually. I have to say that all unanswered questions will be answered actually through the Q&A widget. But I have one final question for you. It's a general one, saying that many women read newspapers or they're doing a web surfing before counseling a physician, a doctor, and they are prone to decline hormone therapy as they are afraid of breast cancer. How can we manage such a challenge? Is there a role for GP or even for the industry? I would start with Professor Tsai.
Okay,
with
this is
his final take-home messages.
Well, this is a very common question I made in my clinic, and we have to persuade our patient. I mean, the concept and the medicine is very different from 20 years ago. We have a better medicine. We have a better regimen. We have better understanding of the property of the estrogen and the progestogen. We can offer our patient with a better regimen of HRT. And in this way, sometimes the patient can accept our the solid evidence from the published literature. Yeah.
Thank you,
Well,
Professor Premitha.
Yeah, well, okay, to a woman, and I'm a woman, so breast cancer is a very personal issue. Women think about breast cancer more than they think about cardiovascular disease or osteoporosis. They think about breast cancer as the #1 problem that they can get, and they don't want it. So trying to come down to that grassroots level of talking to them and trying to get them understand the whole situation, what is better. It is very difficult, I must say, but it is more of listening where they are going, and trying to make them let them talk first, and trying to get them to for us to understand what their fears are, and addressing those fears, and then skewing that direction to the benefits. And I think slowly you get into that trust zone with that particular woman. And so she then knows that, you know what you're talking about, you know that you're going to deal with safer hormones for her, you know that you're going to be followed up. And in that way, hopefully then, if she needs it, she does go on menopausal hormone therapy.
Thank you very much, Premitha. And it became obvious that having breast cancer is very different from dying from breast cancer. With a long-term survival of more than 90% nowadays, breast cancer is similar, a benign disease, let's say. Of course, there are difficult situations, but things are much better now concerning this. Dear colleagues, we have arrived at the end of today's webinar. I do hope that thanks to our speaker and our audience, we are now much wiser regarding the prescription of the most suitable estrogen and progestogen regimes for achieving the maximum breast safety. Finally, I remind you that today's webinar will be shortly accessible on the IMAS website. Thank you very much for your kind attendance. Bye-bye.
Bye-bye.